This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
Hello, and welcome to a bonus episode of Daughterhood, the podcast. I'm your host, Roseanne Corcoran, Daughterhood Circle Leader and Primary Caregiver. At Daughterhood, we hear your challenges in navigating the healthcare system and how it can be both frustrating and disheartening. In each of these bonus episodes, I have the pleasure of speaking with Daughterhood founder Ann Tumlinson, where we will bring the caregiving conversation to a different level with change leaders and policy experts. I hope you'll join us. David C. Grabowski, Ph.D., is a professor of healthcare policy in the Department of Healthcare Policy at Harvard Medical School. His research examines the economics of aging with a particular interest in the areas of long-term care and post-acute care. He has published over 200 peer-reviewed articles, and his work has appeared in leading peer-reviewed journals of economics, health policy, and medicine. From 2017 through 2023, Dr. Grabowski was a member of the Medicare Payment Advisory Commission, MedPAC, which is an independent agency established to advise the U.S. Congress on issues affecting the Medicare program. Today, he joins Ann and I in discussing how policy affects nursing home quality, the fragmentation of payments in the long-term care system, staffing requirements, accountability, and how to advocate for change. I hope you enjoy our conversation. I think we can all agree the long-term care system in the U.S. is broken. The support for home and community-based services is meager. The nursing home system, we hear a variety of things that will, quote, fix it. More money from Medicaid, mandatory staffing numbers, removing real estate investors from ownership, more regulations, less regulations, the list goes on and on. David, I don't know if you can pinpoint it to one issue, but what have you found to be the biggest challenge in the long-term care system?
All of the above. So thanks first, Roseanne, for having me on.
Sure, thank you.
You just listed a whole series of problems, and the long-term care sector, if we're really going to transform how we pay, regulate, deliver, organize care in this country, we need to take on all those issues. I think it probably starts with payment and financing. We have this fragmented payment system. I've written a lot about it. Ann's written a lot about it. It creates all these unintended consequences, and we underinvest in Medicaid and push a lot of costs over to the Medicare program and to families and their caregivers. And that's really the point of this podcast with Daughterhood. A lot of daughters out there are bearing these costs that the system can't handle and cover because of the fragmentation. So I think if I was going to start somewhere, I think all of those issues you raised, I'd also want to highlight accountability, that we, even when we do pay enough, those dollars don't always go to direct caregiving. They often kind of get siphoned off into other parts of these very complex owned companies. And I'll try to be kind there in saying that, but we know we have real estate investment trusts and private equity groups, and the dollars don't always flow to where I think we in the policy community would like them to flow. So really payment, and then on top of that, accountability.
And with the change in staffing that just came out, how do you see that? Is this a positive thing? Is this something that they've done almost to be like, we're addressing it, but it didn't go far enough? Like, where do you see that coming in?
Yeah, I'm really glad you asked about that. This is something, and Ann knows this well. We've been talking about minimum staffing standards, at least a federal staffing standard, back to the 80s with the 1986 Institute of Medicine report. So first of all, huge credit to the administration for finally doing this. That said, they're taking a lot of heat from both sides. I think industry is wondering how they're going to pay for this. A lot of advocates have said this doesn't go far enough. I can see both sides of that. I had hoped that the standard was going to be a little stronger than it actually is. So just very quickly, it mandates a minimum number of RNs, registered nurses, and a minimum number of certified nurse aides. But it says nothing about licensed practical nurses. And so overall, we get a pretty low overall hours per resident day in terms of total staff. Implementation is also pretty slow here. Some of the provisions won't be implemented for 3 to 5 years. And then on top of that, there's a lot of exemptions built into the rules. So I really worry about how much this is going to move the needle. And I want to go back to the prior question. I started with financing and accountability, but I really think low staffing is a huge problem, but it's not the root problem. It's a symptom of a system that's broken. And we need to take on this entire system. So the reason we're going after staffing is because for years, I think we've underfunded and not held nursing homes accountable. So finally, let's hold their feet to the fire and ensure that there's a minimum number of staff in these buildings. But we still have a broken financing and payment system. We still have a broken oversight and regulatory model. There's a lot of work left to be done. So I hope the minimum staffing standard is the start, not the finish line.
Yeah, it's a little bit like, I was trying to think of a really good metaphor, but I mean, David's been quoted, and I love this quote, which is that, just to restate, this is not, the staffing isn't the root problem. The problem is really the money that, that we're making available for care in this country relative to the people who need it and the level of care that they need. And so I feel so sorry in a way for the administration, because they are between a rock and a hard place. Yeah. And they are, getting no credit for doing a really hard thing, and trying to, but this is the worst time to try to do this. Like, yes. We're at this, would have been really good if we could have done it 10 years ago. And then we would have been in a position to say, hey, we don't have a pipeline of workers the industry would have had a chance to prove that they could meet the standards. We could have had higher standards. And then we could have been in a position to say, we don't have the funding or the pipeline of workers to continue at this level of care. And then maybe we could have gotten more into root cause, but we're really not there. And I think one of the things that I've seen policymakers really struggle with, and I struggle with a little bit, is like, okay, I have sympathy for the nursing home operators who can't find workers and are getting paid what we know, like a Medicaid daily rate is less than a Holiday Inn stay. So, I get the challenge there. And yet, at the same time, we know that there are owners in this industry making a lot of money. So so I think the frustration is, to David's point, it's like, how do we divert that money into wages that might actually attract staff? And one of the main ways they're making money is through this thing called related party transactions. So it's not, the Medicaid rates are low, but there are all these people living in a building, and those people use a lot of healthcare, and that help those labs, prescription drugs, Part B therapy, primary care to some extent, so there's all of these things. And sometimes these owners, and this isn't necessarily a bad thing, let me just be clear, but there are lots of different companies that are making money, and sometimes they're owned by the same people. So that can actually be good, because it can deliver coordinated care. And if that's the way they make money, Like it's not like state Medicaid agencies are going to be like, you know what, let's not do that and let's fund this fully instead.
Mhm.
So it's
Yeah,
complicated.
yeah, it's absolutely complicated. And you described this tension well. And I think that I always come back, like when I first read the policy, the exemptions really jumped out to me because that just shows you how broken this is. If you can't find staff at the existing prevailing wage levels and payment rates, and Ann just went through, Medicaid is not a very generous payer of services, you're exempted from this minimum staffing standard. So wait, you're going to put residents in those homes at risk? Shouldn't the policy be, we're going to give you a wage pass through, we're going to pay, we're going to give you more Medicaid dollars, something to help you find the staff? No, you can just staff below what we think is a safe level, and a level that's going to produce high quality care. That shows you how broken this is. And final comment, and you're exactly right. 10 years ago would have been the perfect time to do this. Yet it's sort of ironic that the reason we have this is because of the pandemic. And yet because of the pandemic, we have even a greater shortage of staff. RNs want to go to, they've always wanted to go to hospitals and physician offices for higher wages. And they'll continue to do that. CNAs are obviously working across the economy at Amazon, at Walmart, at McDonald's. They're making higher wages, and the jobs can often be less challenging, maybe less rewarding. And I do like something the administration has done that I've never seen before. And they put in $75 million for training. They use civil monetary penalty dollars to help train the workforce. That's so important. I've heard a lot on the industry side say that's a drop in the bucket, that's not enough money, but it is really exciting. We all know that we need to grow this workforce. That's a good start. I'd love to see more kind of loan forgiveness, childcare type subsidies, anything to get folks working in these jobs. And then all right, I said that was a final point. You got to cut me off here, Roseanne. But one final
we could talk about this for an hour. Yeah,
no
we really
doubt.
could. But the LPNs, I've always loved these ladder programs that allow CNAs to graduate into that. I'm worried if they keep the rule as is, we're not going to have LPNs in nursing homes anymore. It's going to be RNs and CNAs. And I think LPNs are really important. Oftentimes they're the workhorses in a lot of these facilities. So that's a part of the plan that if
I don't
they
get
ask
it.
yeah, they need to be in there.
I don't know. I wonder what the rationale. I don't know what the rationale was for that, but it does.
There is an app report that was released last week, I guess, that showed, in terms of the production of quality care, LPNs were less important, but I would still argue they are important. And I really worry you're going to see a change in skill mix towards CNAs and meeting just the minimum number of RNs and then fill out the rest of the staff with CNAs. That's not a good model.
Yeah.
Well, part of the problem is it's the lack of focus on the residents. I mean, there are people that are living in these buildings. So you're talking about these numbers, and I don't think anybody that is making the numbers is actually thinking about the care that has to happen in these buildings. And that disconnect is a huge disconnect, because that's it. We're talking about people. And the fact that it's been 40 years, and I think it's part of that. We've all changed. We've grown up, and we're different. The older generation accepted whatever they got. They just went along. And now we're coming up and being like, wait, this doesn't work. Like, this needs to change. I realize that this is how it's always been, and people are turning a blind eye to it. And now it's different. But the care that people receive or don't receive in these communities is horrible. It's just, there's not a strong enough word for me to use.
Right.
I couldn't agree. Yeah, you're 100% on there. And the rules as they're currently written, they don't specify a staffing number. Obviously, this new rule will, but it says, you're to staff at a level that maintains safety and well-being of the residents. And that well-being part there is going forward really important. I think that's what you're driving at.
Yeah.
That it's about quality of care and quality of life. And we've all been in nursing homes that are understaffed, and you can tell the difference very quickly. And so, yes, a resident may be safe, but that doesn't mean they're well cared for. And I think there's a real gap there. And we have a lot of work left to do. And the final point here is that, in the original sort of work by CMS going back, 40 years, as you said, there was a lot of interest in time and motion studies, and your point, figuring out how long does it take to actually do that. I don't know how much CMS went about those kind of studies this time. It's not just that the labor market is tighter today, the kind of person receiving care in a nursing home is has much greater needs today than they did 40 years ago. So the idea that we could rely on time and motion studies from decades ago and not even staff up to that level is alarming.
I know. I was like just thinking for a minute about the human being in the bed, 2 hours or 2.5 hours of seeing like think about all the needs a human has for the day, to go to the bathroom, to get dressed, to get showered, to get fed. It doesn't feel like enough time. And the weird thing, we're going to talk about nursing homes this entire time, but the weird thing is that, so yes, to everything you said, Roseanne, I love tensions, obviously. I like, yes, but like at the same time, we hear from caregivers, and actually there's a young man on my team at ATI who is in this situation right now, who are fairly desperate to find a nursing home bed because the situation in the family, and this is somebody who can pay privately even. This is the situation, the family has become so unraveled for a variety of reasons that they really need to have an institutional level of care for a particularly complicated situation in person, and they haven't been able to find one. And so the administration comes along and they put put this staffing thing in place, and meanwhile already there are empty beds in this is a suburban, like outside Cleveland, Ohio, I think. So, like semi-suburban rural, they can't put this person in the bed because they don't have the staff to take care of him. And so these are not good situations much of the time. And yet families are somewhat desperate. Because this gets maybe a good segue, we don't have the home and community-based system in place.
Right.
And that's I'll just sort of chime in here and say, I feel like that's a really hard kind of boat to row, because as hard as it is to deliver services of that level within a facility where there are lots of people who can be served efficiently, you get people into individual homes. And now we're talking about getting caregivers into individual homes, interacting a lot more with the family and the family dynamic and all the family issues. And it's a challenging thing. And we're doing it in Medicaid. But David, you've recently written about this, but we're just scratching the surface. I mean, number of people being served in the community through Medicaid, which is the only other real payer out there, compared to the people who need those services, it's just a tiny fraction. It's just really small. So that leaves the nursing home. So here we are talking about staffing standards when really, we should be. It gets back to the system, the big system, Roseanne, the way you posed that question originally to David.
I couldn't agree more, Ann. It's about balancing the system. And people always ask me, why are you talking about nursing homes? Nobody wants to go to a nursing home. I said, it's about building a strong long-term care system. These countries in Northern Europe, like the Netherlands, that invest far more than we do into long-term care, guess what? They also have nursing homes. They just have much better nursing homes. They're better staffed. They're more home-like. And guess what? On the other side of the fence, they also are working on the system in terms of home and community-based care. And that's where they're really outpacing us. And there's hundreds of thousands of people on wait lists for Medicaid. And I would imagine there's a lot more people out there that just haven't put themselves on a wait list that need these services. So I think Kaiser Family Foundation had a number like 700,000 individuals on these wait lists. I mean, it really kind of makes your head spin. And really kind of angers me. The Biden administration did try at several points to put real dollars, more dollars into home and community-based care. They've largely been unsuccessful. I would love to see us grow those services. You mentioned we had done some research recently. we looked at what happens when states invest in home and community-based care. Guess what? They do actually generate some savings for nursing home care. They draw some dollars out of there, out of the nursing home side. So $1 spent on home and community-based care actually saves 26 cents in nursing home spending. So it's not free. There are no free lunches. You still got to spend money, but it's a great way to grow the system, and it's what people want. So there is both that savings in terms of less nursing home use, but guess what? You're also getting care in the home, and that's what people really want. And I'm sure you're still waiting to hear somebody say they want to go to a nursing home. Nobody wants that, but I've heard lots and lots of friends and neighbors and colleagues and on say, how do I get care into my home, or have my family member go somewhere in the community?
You wonder, because that's, everybody wants to age in place, right? That's the thing. I want to stay in my house. I want to age in place, but there aren't those supports. So when you look at this quagmire, how can we try to move that to support in a better way people living at home? Because there are gaps in that system, and there's waste that's built into the system. So how do you tease that out to make it actually productive?
So 2 points, and I'm sure Anne, I'll take the easy ones, and Anne can take the hard ones. Or there actually, every one of these is hard, or we wouldn't have done it. They're all hard. There's no low hanging fruit, or we would have picked it. Everything's way up the tree, and it's going to be hard. But the first is what I just said: spend more money. Like, we underinvest in these services, especially in certain states. Let's give credit. Some states have been ahead of the game. The Minnesotas, there are states out there that are really further along in terms of growing community-based long-term care, but there's other states that have lagged behind. The other, and this actually goes back to a piece that Ann and I wrote with Bob Kramer, it's about navigation. First, we need to build these services, but two, we need to help families find these. And I thought of our piece just earlier this week. I had a colleague, he's a physician, email me and say his mom was starting to look at services in the Boston area. Where does he start? And very smart guy, has some resources, but no idea kind of what's legit, what's not legit in terms of these services, which places are good, which aren't. He needed some navigation of the system. And Ann and I wrote a piece in The Hill called "A Road to Nowhere," and it's really like we don't have a compass, and we don't have anywhere to go with our system. So, Roseanne, we both need to get some direction and help people kind of where to go, but we also need to be able to ensure that folks can afford these services, and those services need to be there. So, Ann, I'll pass the baton to you, and you can.
No, that was great. It's funny. I am knee deep right now in writing a blog for Daughterhood about this, like what I'm calling kind of the meta question, because it's like, where do I even start? How do I start? It's like, where's the front door to the front door? Yeah. It's the question
if you can find it, Anna, tell us, because I don't know that it's where it is.
I know. It's like the question, it's like, where's the one place you can go that will help with all of the questions? It's like the question about where to go for the question. So anyway, it's a hard thing for, I think, a lot of folks to wrap their brain around, because it's not that infrastructure is missing. We do have agencies, and we do have, I think, that many hardworking, amazing people in the public sector trying very, very hard to meet the need for that. But I had somebody tell me, and I'll get back to the bigger question, Roseanne, in a minute. Okay. But I had somebody tell me, I won't say where, it was a Department of Aging in a big city. And they said to me recently, we have some great programs to help caregivers, both in terms of respite and in terms of navigation, but we're afraid to advertise for them because we won't be able to meet the demand if we do. And I was like, so this is where we're at. This is where we're at, that this poor, awesome person who's trying so hard is like, she can't be like, hey, caregivers, this is what we do. Here's who we are. Come here and we'll help you, because God forbid all 1 million caregivers in this large city were to rush over, they would be having to turn people away. So I kind of, I feel like that piece is important, and the funding is important, and investing in the services. I'll say just two things. One, about the services and about Medicaid in general is like, I think the more we have a colleague, David and I have a colleague, Mark Cohen, and he's doing I saw a paper that he's either just published or is in draft, and just how very poor people are who have this need and live in the community and still aren't eligible for Medicaid. Like, Medicaid really is not, there are a lot, and we call it a forgotten middle, and David's done a lot of work on this. It's that is a big middle. Like, there's a lot of people who are low middle and even not even middle who are not getting services. And I don't know, like, we got a note from somebody into the Daughterhood inbox one, and it was like her father's house was caving in and it had roaches, and she moved him into a trailer, and now there's all these expenses and she doesn't have the money to pay for it. And this brings me to kind of the thing I want to make sure to mention, which is I do think we have to, when we're investing, services, infrastructure, housing. So we don't have good housing options for low, even middle income seniors. We have this very expensive world of sort of senior living and assisted living, and hasn't really figured out a financial model that will enable it to serve more people who are more of a middle income. And David's done a lot of work on this as well. So I think it's like the investments need to be in the services, the workforce, the infrastructure, and the housing, just everything.
Just everything. It's okay.
And what we're not talking about at all is insurance. So we're not even talking about like, how would we pay for all of how, when somebody does have that need other than Medicaid, even if we could get Medicaid to pay for more people, we still have all these other people. And how do we get the services? We don't have an insurance-based system. And it's probably, I don't know, is it too late? I feel like it's too late. Our baby boomers are already, like, the idea of insurance is that, you buy it before you have the need.
Yeah.
Mm-hmm.
So
I think, and I thought you were going to, Mark's done a lot of great work, and one of his real areas of focus has been on a federal long-term care benefit. And yes, it's expensive, but gosh, all these gaps that we've been discussing, need for community-based services, paying the workforce, caregiver support, home-like nursing home care, those could all be addressed with a federal long-term care benefit. Obviously, that's not the end-all be-all, but it's a start, and something that a lot of us have advocated for, but it's expensive. And you don't hear a lot of enthusiasm. And as Ann said, if we're going to start doing this, the time to do it probably would have been 5 years ago, 10 years ago. We still could, but it's getting dicey, and it's challenging. Washington State has obviously embarked on a program, and they're doing this, and same thing, you're paying in for a period of time to get this benefit, but it's challenging to set up. I wanted to also reflect, Ann, on this forgotten middle very quickly. These individuals who are, as we like to say, too rich, in quotes there, for Medicaid, yet not wealthy enough to buy services that are out there in the marketplace. That's the group that would really benefit from a federal long-term care benefit. A lot of people point and say, hey, we already have Medicaid. Why don't we have public long-term? No, we do not. There's a lot of individuals that are falling through the cracks right now. And that's the group I think about when people say, well, wait a second, doesn't everybody either self-insure and they can buy into an assisted living community on the wealthy side, or they qualify for Medicaid? And this is not a bimodal distribution. It is there are folks at every point in that distribution in terms of income and assets. And unfortunately, given the Medicaid rules, there's a lot of people in that forgotten middle. In that paper you mentioned, we kind of estimated the numbers, and it's increasing with the boomers. And I'm really glad, Ann, you raised housing, because that's this like third rail that very few of us in long-term services and supports even want to talk about or address. And people tease me, but there's a whole housing group at Harvard's campus that we don't have a lot of interaction with. They tend to do their thing, we tend to do ours, and it's not just a Harvard problem, which like we have plenty of them. It's a kind of a problem in our field of just how siloed we are about housing. There was a great piece in the Boston Globe this week about just there's not enough subsidized housing in this state, and a woman who had gotten services sort of saying, I feel like I've won the lottery. It shouldn't be winning the lottery. It should be something that we're providing for older adults. Otherwise, as Ann said earlier, they're going to end up in a nursing home.
This is a really cheerful call.
I know. If we haven't
Podcast, I should say.
Oh, yeah, right.
This is not.
No, because it makes you feel like, well, then what do we do? And I think part of that issue is people don't think about this. So in the general public idea, it's
That's
you're
right.
going to pay for assisted living, not realizing how much assisted living costs per month. You're going to go to a nursing home, again, not realizing anything that happens there, or you're going to stay in your house. And that's the way it is. And then when they get into the situation and go, wait a minute, this is too much money. This is not where I want to be. And then it's kind of like, what do I do? And it's too late at that point because there isn't that understanding. So what's the ask? How do we fix this? How do we because there's a lot of branches on this tree. So
Absolutely.
what do we do?
No, I think you framed that really well, Roseanne, that when we do these surveys, and other groups have done them, where they ask older adults or middle-aged adults, like, how are you going to pay for your long-term care? They think it's Medicare. By the way, Medicare does not pay for long-term care. And they're like, what does it cost? People don't have a good sense of what these services cost. And so they're all over the map. I think there's really poor information for middle-aged adults about long-term care. And a lot of them, I think, go back to thinking this is a family issue and we'll deal with it. I'll care for mom or dad, or you'll care for your spouse. And yes, it's a family issue, but I don't think there's an appreciation of the idea that this is also a policy issue. And our old colleague, late colleague Josh Wiener, used to say this a lot, that it's both, and we really need to think about both. The family side, it's always going to be a family. There's always going to be caregiving. Daughters are always going to be a part of these caregiving teams. We know that, but how many of us know in our 50s or early 60s that, hey, it's also an important policy issue, and we should be contacting our representatives, and we should be advocating for increased Medicaid home and community-based service coverage, starting along the path towards a federal long-term care benefit. Why is that the missing piece? And we were talking earlier about fragmentation. All of our healthcare services, for the most part, are covered under Medicare. The one big gap, the largest source of kind of uncovered spending for older adults, out-of-pocket spending, is long-term care. Why? Why do we choose to go this way and these other countries actually have pretty generous benefits? Like unfortunately, I think we're the ones that are not sort of seeing the real problem and how beneficial these services are. So I hope that we can educate more families, and this is where Daughterhood really is important, like really hammering home to representatives. This is a policy issue we care about. We want to advocate for increased coverage, increased benefits, living wages for our caregivers, cash and counseling support for family caregivers, and on and on and on. You said all those branches. This is, I can't list all of them, but we need all of those services, but we need to continue to educate our policymakers, because otherwise I think it's going to continue to be this forgotten middle, who's basically, these are families that are then going to have to figure this out themselves, and it's not going to go well for most of us. So we see this time and time again.
Mm-hmm.
Yeah, I totally agree, and I would say one of the things that we are hoping to do in Daughterhood more and more is to sort of help. We've even had a Daughterhood circle on how to be an advocate, how to working with our partner organizations. Obviously, there are many working in this space, but I think we're all a little nascent. Family caregiving hasn't really been. I think we're like at a little bit of a Malcolm Gladwell tipping point. I think as the overage, as we go with our older adult population, where we've had mostly 65 to 75-year-olds, we're getting ready to shift in terms of the growth rate into the older adults. And that there's just, I think, you can sort of feel, I think, the momentum a little bit around family caregiving is like, oh, there's just more and more people being affected by this, and it's getting elevated. And so hopefully, as all of these other organizations that have been in this space a long time are strengthened by that, we can work together and give caregivers a voice in the, in the policy conversation that I think will resonate. And one of my mentor and guru of policy, Chris Jennings, was said to me, it was like, how do we get the drug pricing law, but not the Medicaid home and community-based services? And he's like, it's just because people were furious about drug prices.
Right.
Like, this is a ridiculous situation, and constituents at the grassroots level were just like, are you kidding me? And my mom was, asking about this the other day, and I was like, it was bipartisan. Like, this wasn't really, the Republicans are complaining about or whatever, but really, at the end of the day, nobody wants to go back to their constituents and be like, oh, you know what? We really want you to pay more for insulin.
Right.
And that's great, but and I love that we're going down that path. But why are drug prices a policy issue in family caregiving?
I know.
It just blows your mind that we're not going to our policymakers and advocating for increased support for family caregivers.
I think we have to. Go
ahead.
Sorry. I'm so sorry. I'm very excited. So
no. I want to hear you on this.
No, I think we have to build that bridge. Just to your very point. I think we have to help people understand it's not a personal, and this is one of our big things at Daughterhood is, and why lots and lots of conversations about the name, plenty of people taking care of family members who are not a parental daughter relationship. But I have observed that women tend to encounter a difficult situation that is systemic and say, oh, I'm failing. This is a personal problem that I need to solve. And so what we want to begin to do is sort of normalize and contextualize that this is not, this world that they've suddenly entered into is not a personal problem. This is a societal problem. And we even had somebody, I think on one of our Daughterhood circles recently say something so profound. She was like, enough with the self-care. Where's the community care?
Mm-hmm.
Right.
And I was like, yes, that's it. We have to take care of each other. And the way we do that is through our systems of government. And they're not so broken that we can't make them work if we try really hard. And to sort of help wrap a little bit on a positive note, David, I'm excited about the dementia model. So the administration came out with this new model they want to test on dementia care, and it's essentially going to pay primary care providers to deliver care management and navigational services. Now, I know primary care providers don't know how to do that, so just hang on, Roseanne. I know where you're going. Bear with me. They don't, but these additional funds will allow them to do is essentially kind of partner up with organizations that do have those capabilities and essentially generate a revenue stream for that. And the cool thing of all of this is that for the first time ever, CMS is recognizing that family caregivers can actually be the receivers of services in Medicare, which is like a very big, I'm sure there are a lot of bureaucrats who are just kind of biting their nails because they're like, that's the Medicare program is for Medicare beneficiaries. But we are going to actually pay for services that are directly going to be delivered, respite and other things that are really for the caregiver. And that is a big change and a big shift that, shows that there's a recognition. So.
You said it well, that for the first time, I think that caregiving is having a moment, and it's just at the beginning here of that moment, and that policy by the Biden administration wasn't, was really representative of the start of that moment. I like supporting caregivers. This is not your older brother's Medicare, right? That's something you would never have seen. I just finished my stint on MedPAC, and I can't remember, like, the Medicare Payment Advisory Commission. Sorry for the acronym, but there's so we advise the U.S. Congress. They're actually meeting today, and I'm here with you. So I'd much rather, I'm done with my service. So this is a good way to spend the day, not in D.C. in a government office building meeting, but rather talking long-term care.
We appreciate you.
So
thank you.
definitely. So, but this kind of issue is not coming up 6 years ago on the commission. So it's really been a huge pivot, and it's incredibly exciting that we're starting to support caregivers, and we're starting to think outside the box, and maybe even, I'll say this very quietly, maybe starting to fund long-term care and Medicare. I guess, we did some of this on the Medicare Advantage side, but maybe this is starting to creep over to the traditional Medicare side. And so it's very exciting, and maybe breaking some of those silos down a little bit that we've traditionally had across Medicare and Medicaid, and people paying out of pocket.
Yeah, that might be the path. I definitely am like, I think of myself as like Robin Hood, I'm like, can we get the money out of the hospitals and bring it over here and put it in this bucket? And,
I'm so glad you said that, because people ask me, and this won't be popular with your physician listeners here, so I'm sorry in advance, but or maybe those hospital CEOs, if they're out there listening, maybe they're not, but that's where, like, people say, well, wait a second, the Netherlands and these countries you mention all the time that spend so much more on long-term care, they spend a lot less on healthcare. That's how they do it. And my response is exactly like, we need to change our sort of national spending and kind of reallocate and our money away from medical care in the hospitals and towards families and long-term care services and supports.
And and another like plug for, that pat on the back for the hardworking people at the Centers for Medicare and Medicaid Services is that they did take on the specialists in the physician world in order to create some of the money that we need to provide training services for caregivers, both inside the regular Medicare program and in this demonstration program. So like, that was clever. And I think they're going to get away with it, and we're going to have that, we're going to be able to do that. And that's I think for many caregivers out there right now who are dealing with this really huge sets of challenges on a day-to-day basis, it doesn't feel like much. And I want to be very respectful of that. They're like, are you kidding me?
Yeah. But it's a start. And I think this hasn't been the most uplifting podcast in some ways, but this is a sign that things are pushing in the right direction. And obviously policy is slow to catch up, but this is an area where, as we continue to advocate and do research on these models, I'm certain that we're going to see an expansion. One of my favorite quotes is from Bill Scanlon. There's no reverse gear in health policy, and that once you give people something, it's really hard to take it away. And like the drug benefit in Part D, and there's a lot of examples of, once you do this, people realize how good it is. And once we start covering their long-term care and giving them caregiving support at home, guess what? They're going to become very reliant on these services, and you can't take that away. So that's my hope also with the minimum staffing standard, that as we get this in place, it's a start to a lot of reforms, but we won't go backwards.
Right. That's a good point. That's a great positive.
Yeah, there you go. We found it. It only took us 40 minutes here, but we got there.
Well, but I think as a dementia caregiver, paying the primary care office to be that point person is huge. It's a gift, because, and all of the dementia caregivers I speak to, you talk to them and you leave the office and it's like, well, good luck to you. Hope you can find stuff. Nobody helps you. And if there could be that, okay, we can talk to you, we can at least give you an outline of what you can look for, instead of getting in your car and driving away and being like, I don't know what I'm supposed to do with this. So that for me is even though it's little, that's a huge, and that it feels like it's a turn, like somebody got to the right person to explain that this is something that is needed. And so that's a positive for me. So I feel like that's a win.
This is a real thing,
Yeah.
Unlike, well,
Oh boy, she stopped.
You know what?
What?
I'm just going to stop myself. This
Yeah,
is
that's
real.
right.
Okay.
This is real. This is real Medicare money going
Yes.
to
Yes.
caregivers so I just want to emphasize this. CMS did kudos. Like,
Yeah.
yes.
Absolutely. And you can have me back for a sequel podcast, and you can tell us what isn't real money, and we can all wait for that. And you can think about that. That'll be our teaser for the sequel
next
here.
one.
We can. That's right.
Mm-hmm.
Yeah,
Mm-hmm.
we'll just leave that alone.
Leave that alone.
We'll
Yeah.
leave that there.
Don't. Some poor person's working on that program and doing the best they can. But yeah, there's a lot of examples, unfortunately, of underfunded and
yes. attended to.
Yeah.
100%.
So for positivity's sake, going forward, actually calling your congresspeople and writing those letters and talking to people and trying to bringing your story to them is helpful going forward.
Absolutely. And I think it helps kind of personalize this for our representatives who get a lot of data put in front of them from people like Anna and myself, and that's helpful. But I think the stories matter more. And I've had the opportunity to testify several times to Congress, and I can say that the showstoppers in those hearings weren't people like me telling you percentages or numbers. It was a family member telling her story about what happened to her mom in a nursing home, or what happened, a caregiver, a CNA at a facility, and what happened when COVID hit that facility and losing one of her colleagues. Those are the stories that really resonate with our representatives. And so I'm not saying there's not a role for data. There's a role for both. And Ann and I promise to keep writing papers, but it'd be great to have lots of people writing letters and telling their story too.
Totally agree. Well said.
For more information about David Grabowski, you can find him on the Harvard Medical School website at hcp.hms.harvard.edu. I hope you enjoyed our podcast today. Head over to daughterhood.org and click on the podcast section for show notes, including the full transcript and links to any resources and information from today's episode. You can find and review us on Apple Podcasts or anywhere you listen to your podcasts. We are also on Facebook, Twitter, and Instagram at Daughterhood the Podcast. Feel free to message me on any of these sites and let me know what issues you may be facing and would like to hear more about. Or even if you just want to say hi, I'd love to hear from you. Also, a very special thank you to Susan Rowe for our bonus episode theme music, Even My Guitar. I hope you found what you were looking for today. Information, inspiration, or even just a little company. This is Roseanne Corcoran. I hope you'll join me next time in Daughterhood.